My name is Michael Betel, and I'm the president and founder of the Fatty Liver Alliance. We raise awareness about the risks, causes, and complications of fatty liver disease and help those already diagnosed with NAFLD and NASH by advocating for access to approved treatments and care. We have a very special guest today, Dr. Karl Nadolsky, who is a clinical endocrinologist at Spectrum Health in Grand Rapids, Michigan, and clinical assistant professor of medicine at Michigan State University. He's a co-author of the ACE 2016 Clinical Practice Guidelines for Comprehensive Medical Care of Patients with Obesity and the 2022 ACE Clinical Practice Guidelines for NAFLD. Dr. Nadolsky, it's clear that there is a reciprocal, I use that word cautiously still, but reciprocal relationship between obesity and fatty liver disease and type 2 diabetes. Whether we use the nomenclature NAFLD and NASH or call out the metabolic involvement with the acronyms MAFLD for metabolic associated fatty liver disease and NASH, let's start today by diving into that relationship. What is it and why is the liver involved in this relationship?
Yeah, so I often say that NAFLD and the spectrum with NASH and fibrosis is really a quintessential adiposity-based complication of obesity. And so when we talk about obesity, people get too hung up on BMI, but it's by definition an excess or abnormally distributed amount of adipose tissue, and everybody's different. We all have different genetic backgrounds, different environmental contributions, and then other things that throw monkey wrenches into the complex nature of our our energy balance, adipose storage, and where it's being stored. And so really I would say that it really is the disease of obesity that's driving these adiposity-based diseases, including NAFLD, and then of course comes along with that the association with type 2 diabetes. And as you know, they both sort of the association at least increases the risk of one or the other.
Okay, so thank you for that. One of the things that frustrates patients the most is when they do go to see their doctor and then they find out for some reason, maybe it's an elevated enzymes or some other
Mhm.
test that they have fatty liver disease. And then they hear over and over again, listen, you got to exercise, you got to lose weight. And we'll see you again in 6 months.
Yeah.
First of all, is that the appropriate response now, knowing what we know, or is there something better that we can share?
Yeah, not exactly. That's kind of like what we say when people present with depression, and we say, "Well, you got to feel better, right? Well, you got to go lose weight." Well, the problem is that obesity and these obesity related complications like fatty liver, diabetes, etc. It's easier said than done. We have a complex pathophysiology, like I said, with a genetic background that really makes it hard, and so we have an energy imbalance that is dysfunctional and tries to drive us towards a higher weight or on an individual basis, right? And it's easy, you just can't go and improve your diet and exercise. We have to do a better job of helping patients figure out how to do that while still understanding we have to address the pathophysiology that's driving it. And that may require medications and surgeries to help them lose the weight, which is really a surrogate of losing fat that's driving these disease processes.
And I do believe that there is more and more attention being given to the behavioral aspects of it
Mhm.
too, because we just heard from a patient yesterday that they have to realize. I know, and I wanted to ask you this question. So you had an aha moment, in your words, with your aunt when you decided to go to be an endocrinologist.
Mhm.
What does it take for a patient to have that aha moment and know, okay, that's it. I'm tired of this, and I want to change, because it has to come from the patient, right?
Yeah, I mean, obviously, everyone has to, want to take care of themselves. I don't know a perfect answer for you, to be honest. I don't know if anybody knows that perfect answer, but I know personally, I really like to describe these disease processes to patients and at least articulate the complexity of it. You know, obviously, doctors, scientists, nobody understands it completely, and so to try to explain it in 2 minutes to a patient in a 20-minute appointment, that's not going to work. But at least embracing the complexity and seeing if we can get them to acknowledge, oh, this is a complex disease process with high risk. And then of course within the spectrum of obesity in itself, we have to try to get them to understand that there is this spectrum of disease severity ranging from relatively healthy obesity to things like NAFLD, higher risk of NASH or NASH, type 2 diabetes, cardiovascular disease. And we don't really want to wait until those are established to be the aha moment, so to speak. And we need to do a better job of education. We probably have to find a way in our whole healthcare system that includes everyone, from you and educational efforts to our nurses, dietitians, trainers, psychologists, to work together and have more time to be able to educate patients and get them to to embrace the disease processes and help address it, and ultimately, yeah, it improve our behavioral efforts too, which it's easier said than done. It's
Uh,
hard. I
I
know.
know. And instinctively, we almost want to fall back on, listen, the end of the day, it's what you put in your mouth. So I'm not sure, does it come down to food choices exclusively, or really is there that genetic and also insulin resistance and all of the other things that are at play?
Yeah, I mean, we want to do the best we can to help people improve their dietary efforts. But again, yeah, that complex biology, and everyone's different, and especially with that genetic background, it makes it very hard. That's why we struggle to get it. Otherwise, we wouldn't have a problem. We have a genetic drive on a with a very heterogeneous individual spectrum of causing obesity and obesity related diseases. So it is easier said than done, but we definitely need to educate people on not only dietary choices, finding individual ways that will help them adhere to, a weight loss diet, so to speak. Again, easier said than done. Finding a way to create an energy deficit, which is the key for treating NAFLD and NASH. But it's hard. If you look at the studies that show, oh, if we can help people lose 10% of their weight, that's where we start to see real fibrosis regression, which is like the ultimate goal for what we're talking about. But a very small percentage of those people achieve and maintain that weight loss over a year because of the drivers of obesity that work against people, fighting that sort of that set point you'll hear about. And you'll hear different terms for that. That's not the point. We could
Right.
debate that all day, but it's hard. And so individualizing dietary approaches, seeing what they already do, what they prefer, what their capabilities are. They might be living in a food desert. They might have cost
Right.
issues. And maybe their upbringing, their ethnicity, their background, all sorts of things we have to consider. And there are many, many different dietary ways to help them create that energy deficit, improve the quality of their diet. A Mediterranean pattern diet is preferred in the context of doing all this, but we can cut carbs, we can cut fat, we can do intermittent fasting, we can use meal replacement shakes, we can do all these things in combination. They're not mutually exclusive. That's my favorite term for this, to help patients achieve it. But it's still hard. We still have the biology working against people.
I bet you would give this advice to people. You can choose whatever works best for you to attain that energy deficit, as long as you can maintain it for life. That's a life decision, right?
Right. Again, easier easier said than
I
done for
know.
different people.
Yeah.
Yeah, that's the thing. But yeah,
But
yeah, of
but
course.
the fad,
Yeah.
that's why fad diets don't work too. They go on and then they change. And now even the medications,
Right.
a lot of them, the way they work right now, as soon as they stop taking them, they gain the weight back.
Well, which is why it's a chronic, recurrent, progressive disease, and all the medications we have are approved for chronic use. Doesn't mean people have to be. We have ways to help maintain weight loss and preventing regain and obesity with all sorts of nutrition habits, exercise up with a higher volume and intensity beyond what got them down to it. But yeah, medications and obviously surgery, because surgery are essentially chronic therapies right now because of that disease process that works against people.
Okay, so just briefly, you said adipose tissue is the problem. The fat there is the
Mhm.
problem. How do people know if that is their problem? Is it weight distribution that's a key to identifying that?
Yeah, so when we talk about the diagnosis of obesity, this gets difficult because it really should be more of a clinical diagnosis. BMI is only helpful on a population basis and maybe just for screening individuals, but we have to understand that in the context of, say, even NAFLD and NASH, there are people with low BMIs, quote unquote low BMIs, that would normally maybe not screen as positive, they who have NAFLD. Maybe they don't have a lot of muscle mass. And so they actually have what I would call sarcopenic obesity, and that might even have the highest risk. So a thin person without much muscle, especially when they're storing what adipose tissue they have in their visceral abdominal area, because that's in their liver, hepatic triglyceride, in their muscles, intramuscular triglyceride, in their pancreas, which is part of the progression to type 2 diabetes, and then that overall high inflammatory cardiovascular risk milieu of abdominal obesity. So waist circumference is another way, but also just examining people. And then the clinical aspect of it is, anybody who has something like NAFLD, type, pre-diabetes, type 2 diabetes, we have to then think, oh, even though they might not have what we thought was obesity, they do by definition, unless there's some other cause that you have to rule out, which can happen too. There are other causes of liver disease that we have to make sure people don't have.
We could talk about this all day for sure.
Yep.
Because there's so many. We are definitely going to have to do this again. I
Yeah.
just want to thank you. I know we're going to keep it brief today for people, and but it's fantastic. I want to have a part 2 to this too, and we can dig deeper. But
Yeah, absolutely.
thank you for what you do for patients every day. I know that they appreciate what you do, and I do.
Sure thing. Absolutely.
Thank you.